Hello and good afternoon. Welcome to the day two of Crisp TV, and we are having absolutely brilliant sessions today. And my name is Dr. Abad Khan. I am your host. Uh, with me right now, I have Dr. N.K. Mahesh, who is head of department and a senior consultant at St. Gregory's Medical Mission Hospital, Kerala. Sir, welcome to Crisp TV, sir.
Thank you, boss.
Sir, now as we know, the imaging has got class 1A recommendation in the ESC guidelines, much awaited so, but that hasn't translated to the ground level increase in the imaging usage, sir. So one part is cost obviously and reimbursement, that is okay, but the other part is that increase in the contrast usage for people who want to do repeated OCT runs for a patient in a primary PCI. You have done great work on saline OCT imaging. So kindly show us some light upon the saline OCT and why it should be done more frequently and about the learning curve, sir.
Yeah. So if you're already doing OCT regularly, there is no learning curve for saline OCT. All that you got to need is to just get your technician to have a manual startup instead of an automatic pullback. Have a manual pullback and have your timing set with the technician. Once that is done, then you're through with it. So how do you get the timing set with the technician? Is that you call the Abbott people from there. They will come and train you how to get the timing set. So your recording starts, injection is given, then a manual pullback is being done. So that manual system of pullback has to be learned. That is the only problem in having doing a saline OCT. It takes about 5-6 runs. After that you will master. And there are few of us, there are at least 40-50 of us who are doing regularly saline OCT. You can call any of us. We'll come and help you to set up the system, and whether it be hand injection or whether it be pressure injection, both of them can be set up for you. And you do 3 cases with us. After that you will be teaching others to how to do cases. So simple.
Sir, perfect. Sir, you have already given a great amount of data and the work you have done on IVUS nurse and great sessions also. Sir, do you think that the saline OCT can be as good, or some nurse IVUS is actually the better modality to go forward as compared to saline OCT, sir?
You're comparing apples and oranges. So the bottom line that I have to say is that if you're doing complicated cases, if you're doing left main cases, if you're doing bifurcations, always do it with imaging. Now what imaging is your choice. You can do OCT, you can do IVUS, you can do IVUS nurse. Absolutely your choice, whatever you are comfortable with. As long as you're doing it with imaging, you will find your results are far superior. IVUS nurse has got its own genre of cases which does well with it. OCT is right now the most powerful tool in imaging with its own drawbacks of the learning curve and getting the synchronization right, and of course the expense. So given an option, you should do all complicated cases with imaging, and what imaging is depending on your social circumstances, your training, and whatever you're comfortable with. Every imaging has got niche areas, like IVUS is for CTO, IVUS is for left main, OCT for ACS, ISR, the stent plaque definition, all these things OCT does better. So you have to choose your line of imaging.
Perfect, sir. Perfect. Perfectly answered. But sir, as a senior cardiologist also, sir, how often do you do? What percentage of cases are your contrast OCT, and what percentage cases of your saline OCT, as in practice?
So in RCA, 100% saline OCT. 100%. There's no doubts about it. In the left main, if it's a huge left main system, or if after the stenting has been done, the left main has become really big and the proximal vessels are big, then I may not be able to get a saline image, in which I don't use 100% contrast. I use a ratio of 50-50 or 40-60 or 30-70 of contrast to saline, so that even when I'm doing that shot, the total amount of contrast is still reduced, albeit not zero. So instead of I take a 20 cc syringe, I fill 5 cc of contrast, and I take 15 cc of saline. I get an excellent shot in a very large vessel in a left main. At the same time, I don't use 20 cc of contrast.
Perfect. So the idea behind what sir is trying to mention is that you have to get used to the technique first. Just making sure you are doing couple of times, and then you will be perfectly right to go. Whether it's a left main also using some amount of contrast, and for RCS, as sir says, that it's absolutely not needed to put a contrast while doing an OCT. Perfect, sir. Sir, what is the future of interventional cardiology, especially in the field of imaging? When you already know that which is already discussed, the Termo is already coming up with a catheter which is an IVUS and OCT on the same catheter. Sir, what's your take on that, and for the future of imaging in interventional cardiology, sir?
So that's just fabulous. If you have the OCT and the IVUS in the same sitting, it's going to be an absolute game changer. I did see the catheter already. I've seen that surprisingly, although they have integrated OCT and IVUS into the same catheter, the size of the catheter has not changed much. It's more or less remained the same. But you should understand that you can't do simultaneously OCT and IVUS. Either you switch on the IVUS part of it or you switch on the OCT part of it. But the net result is that we get excellent images. That is the future forward. I think let it get launched. It will have its own plus points and minus points, but imaging is here to stay.
Imaging is here to stay, and imaging is definitely improving by leaps and bounds. The technology, as the technology improves, sir is correctly saying that. Sir, also, sir, you had a brilliant talk on the bifurcation angioplasty, and a new device has come up, the biomime stent. So, can you please elaborate on the part of the stent?
So there is two schools of thought when it comes to dedicated bifurcation. There is true bifurcation. The Eastern school of thought is called DK crush. They all want DK crush. The Western school of thought is called EBC main. They predominantly use Kilot. So a dedicated bifurcation stent is a modified form of Kilot, in which there are dedicated struts at the head and there is dedicated struts in the side branch. In between it is by connectors. So it's basically I'm doing a Kilot stenting with a modified stent, because of which across the carina there are relatively much less metal load. So that is the aim of doing all this. So A, the metal load is very less. B, in Culot we have a problem that the vessel should be same size. In this case, since it's a tapering stent, that is, you can have 4.5 millimeter proximal and 2.5 millimeter distally. So the size disparity is not a factor when you're doing with this stent. Otherwise, in Culot you cannot have two different, there should be 3.5, very small variations can be permitted. So size disparity is not a matter. The number of struts across the carina is not a problem, much reduced. The metal load is very used. DK crush has got 17 steps, and the recrossing is a big problem because you got to go through two small square areas. Here you got only one small strut of the main vessel. The other one is practically a straight metal, so it will not create a problem for you. So crossing, recrossing becomes much easier. Instead of 18 steps, you got about 9 steps to do here. It's a much more comfortable thing. Only thing that it has not been promoted enough and it has not caught the eye so far. So we are doing the first study. 22 centers are taking part in. We will have 1 year outcome in about 1.5 years time. Probably that will once that article comes out, it will be more. Even now today I got a lot of questions, a lot of queries, a lot of people had doubts. I go to different places, do cases there so that they are aware of it. So slowly it is spreading, but once the people get the hang of it and it is polished to small nitbit problems are there, once that is sorted out, this will definitely be a good modality.
Perfectly put. And sir is an early adapter to the technology, and why should not he be? He has done some excellent work, and he's been doing great on that part also. Sir, before ending it, sir, some rapid fire questions to you,
Yeah.
sir. Sir, in your day-to-day use, you may choose to answer whichever way you like, sir. OCT or IVUS, one imaging modality, sir.
OCT.
OCT. Sir, Cephalus vein triple vessel bypass versus an perfectly placed image guided triple vessel stents.
That's not even a question. Perfectly imaged triple vessel stents.
Great. So triple vessel bypass is absolutely not somebody
No,
will
there are when I'm pushed against the wall and I can't do it and the synthesis score is very high, you should take the correct judgment. If I'm given an option of choose one or the other, I'll go for stenting.
Perfect.
But I would obviously give the patient condition first.
Good. So, some medical therapy in stable angina or PCI.
So I would like to put the guy on a stress. If he is tolerating the stress well, I'll go for a medical therapy. If he is not tolerating well, he is symptomatic. Then it's been proven that there is no long-term life gain because mortality benefit nahi hai. So I would rather, if he is asymptomatic and is doing well and is able to do all his activities without any restrictions, medical management. If there is symptoms, address the symptoms.
Even pushing it further, some medical therapy versus PCI in a CTO.
In a CTO, now again, it is always better, in my opinion, to tackle the CTO and leave it open. You see, you are borrowing food from the neighbor. That fellow is giving you food. One fine day he will run short of food, you will not get food. Correct? So LAD is giving the RC or CTO a lot of blood because LAD is rich. One day when the LAD develops a lesion, then LAD will not be rich enough to supply the RC. So by that time, if the RCA is already opened, they will be mutually beneficial. So it is not fair on our part to leave a dominant vessel CTO. Small vessel CTO may be symptom related.
Perfect analogy to that. Somebody should learn that food is very important for anyone. Sir, to end it off, sir, tea or coffee, sir?
Coffee.
Coffee. We are just running out of options on tea, and we do not have enough guests now. Thank you, sir. Thank you so much
Pleasure.
to be on Chris TV, sir.
Thank you.
Thank you.